I'm delighted to introduce Professor Nam-Han Cho again. He is the President-elect of IDF Europe. So, I'm very much focused on the region, you know, this is my fault. Okay. He's the President of International Diabetes Federation, President-elect of International Diabetes Federation, and will serve as the President of the organization starting from 2018. He is the Associate Editor of Diabetes Research and Clinical Practice, and he received the Chivalric Royal Order with Grand Officer insignia from the King of Kingdom of Cambodia in July 2015, and he still serves at the Arjun University School of Medicine as Professor of Preventive Medicine. So, thank you.
Thank you, Shanna, for your wonderful introduction. Now I'm chair of or president of the International Diabetes Federation in Europe, right? Thank you. Anyway, a couple hours ago, I presented a high-risk population, which is elderly population and pre-diabetes group. But this is another group you're about to see or you'll be encountered during your professional career in Egypt. And I've been told the gestational diabetes issues not yet to covered in Egypt, so I'd like to share the matters related to the gestational diabetes. As you all know, gestational diabetes, acronym is GDM, is defined as carbohydrate intolerance with the onset of first recognition during pregnancy. So the fact in uncomplicated and the GDM pregnancy in normal pregnancies are characterized by insulin resistance and increased insulin secretion as a compensatory mechanism to maintain normal glucose tolerance. However, in gestational diabetes, subjects decrease the insulin sensitivity and more pronounced insulin resistance phenomena is occurring. And this phenomena might contribute to the hypoglycemia in addition to defective insulin release. So there are several kind of the way to diagnose the GDMs, but the mostly frequently used one is the Carpenter-Kusten criteria, which is widely used in the United States. If the four values, two of those are exceeding, this is considered as a gestational diabetes. For example, fasting with greater than 95 milligram per DL, 1 hour 180, 2 hour 155, and 3 hour 140. If any of those two values exceeding, considered as gestational diabetes. Another widely used the diagnostic criteria is NDDG, that's the National Diabetes Data Group, again from the United States. Criteria has been used, and this criteria is slightly or more liberal. As you could see the values there, there are 105, 190, 165, 145. And there are also in IDF criteria there, WHO criteria there, but these are the two most widely using diagnostic criteria. Let's start out with the prevalence of the gestational diabetes, how serious it is. This figure shows our 7 regions in IDF. You could see the Southeast Asia, which include India, with a prevalence of the 26%. 1 out of every 4 pregnancy, they are diagnosing with gestational diabetes. Numbers more than 7 million women with the pregnancy. Next to 2 region is followed by Western Pacific, you could see the right side, and MENA region, which includes Egypt. So numbering is almost 4 million on both sides. So what is this indicating to you? All Asians are high risk for gestational diabetes. Southeast Asians are highest, and followed by MENA and Western Pacific region. So this is the prevalence of gestational diabetes using a WHO criteria. As you could see again, Indians showing the highest rate. That was way back 30 years ago. The reason I'm showing this figure is now they're reaching 26%, where back about 30 years ago it is 3.5. So almost 8 times it increased during 30 years' time. This is the study conducted among the Korean population. You can see the left side of the slide, Caucasian living in Chicago, African American living in Chicago, Hispanic living in Chicago, Korean American, they are immigrants from Korea living in Chicago. I conducted this study in 1994 when I was in Chicago. As you could see, Koreans migrate to Western culture, the prevalence of gestational diabetes was about 9%, where in their home country it's only 2%. So almost 5 times greater risk just moving into Western culture. Suwon is where all of you know there is a home of Samsung, your mobile phone, also a home of my university. Our university is known as the clinical care for gestational diabetes. That's why it's showing the high rate of gestational diabetes. However, the national rate is about 2% back in 1994. Look what happened in Korea. In 2015, that rate increased to the 15%. You remember previous slide? It was 9% when Koreans immigrate to United States, Western culture. But now they don't even have to immigrate to the United States or Western culture. They leave their home country, their rate is 15%. They rise from 2% to 15%, 7-fold increase from 94 to about 20 years? 30? 94 is 20 years, am I correct? So what is happening here? Western culture is migrating to East, so we don't have to, Asians doesn't have to move to Western culture to be high risk for gestational diabetes, and that is also true for type 2 diabetes. These are the risk factors found so far. Pregnancy in older age, definitely a high risk for gestational diabetes. Greater BMI, greater than 25, more parity, family history, ethnicity, again, ethnicity here, I'm referring to Asians, including Southeast Asians, Western Pacific, or MENA region. Previous history of macrosomia, pregnancy weight gain as little as 9 kilo, you put it into the high-risk group for gestational diabetes. Migration to Western countries, now Western culture migrate to the East, your risk. History of fetal death and abortion, show status, and genetics. Let me show you, because again, time being, I cannot get into the details of these risk factors, but let me show you some of those findings in show status. There is 2 studies being reported. One of them is from my group, one of them is from the Branch-10 groups, and as you could see, if you are short, less than 145, 1.45 meter, prevalence gestational diabetes about a little over 10%. But if you're tall, greater than 1, the rate decreased about 7%. Actually, it's not a height. It is how well you are nourished, or during your growth period, how well you eat. So it is like a nutritional and malnutritional fact and relate to the diabetes. So why it is so important to look at the GDMs? There's 2 aspects. One of them is adverse outcomes in offspring, their children, high risk for diabetes who experience diabetes during pregnancy. So let me start out with adverse outcomes in offspring. Oops. Okay, I don't know, most of you probably remember Norbert Frankl. He was my mentor while I was in Chicago. He was also president of ADA, and this is the hypothesis. It's very well known. It is the textbook, the hypothesis, Frankl hypothesis. What happens is during pregnancy, maternal diabetes condition do have an effect on offspring. So amino acid, fat, carbohydrate can cross the placenta if your mother's diabetes is not well controlled. then it reaches the fetus. It is like overfeeding them, high nutrition there. So we find out during our follow-up study, in fetus, we withdraw the amniotic fluid during their pregnancy, and we measure their amniotic fluid insulin that was elevated because there's high nutrition across the placenta and went to the fetus. At birth, because they have a high excess insulin, they become a hypoglycemia. And of course, they're overfed, so a lot of kids or babies born with macrosomia. Because macrosomia, they continue to be obese, and they have a high rate of developing metabolic syndrome, then further on to IGT and DM, and also starting developing cardiovascular risk factors too. So we have a new theory beside a Frankel hypothesis. There is a theory called diabetes begets diabetes. So let's look at the short-term effect. As I indicated in previous slide, because they're overfed, kids big, so large for gestational age, offspring of gestation mother showing about 40% are affected with a large for gestational age, whereas non-diabetes is only 13.7%, showing about threefold high risk for large for gestational age. Also macrosomia, you all know what macrosomia is referred to as greater than 4 kilogram at the time of birth. So again, they're about threefold higher risk for macrosomia being in GDM. This is what the macrosomia looks like. Left side is normal baby, right side is macrosomic baby. They're huge. That's not it. As you could see, that's what we call the symmetry index. One is symmetrical. If it goes 1.2, that's what we call the obese. If you go well behind the 1.4, we call the grossly obese. So look at how their weight gains in offsprings. They continue to decrease 1 year because mothers start to give them diet feeding methods, so they continue to drop. But when they start to learn how to open refrigerator, they are feeding themselves, they become very grossly obese. So you probably don't know how big this is. This is the kids. They cannot walk straight through your normal door, room door. They have to go sideways. That's how big they are. What about the neonatal complication? As you could see on this slide, we compared the DM, gestational diabetes, and normals. You could see the percent of the transient hypoglycemia, 52. I'm sorry, it's not a percent cases. GDM 28, normal 3. They are statistically higher in DM and GDMs. And persistent hypoglycemia is also higher in DM, GDM. Hypocalcemia, hyperbilirubinemia, transient tachypnea, polycythemia, RDS, IUG are all high in GDM and offspring of DMs as well. This slide depicts the major adverse health outcomes in offspring of diabetic mother, comparing normal versus GDM and DM. I combined the two groups. As you could see, they're about threefold higher in offspring with GDM mother for CNS, congenital heart disease as well, respiratory disease, intestinal atresia, anal atresia, renal and urinary tract defect, upper limb deficiencies, lower limb deficiency, upper and lower spine, caudal dysgenesis, all significantly higher in offspring of GDM and DM. This is how significantly impacting mother's glucose control to fetus. What about the long-term effects? There's just so many data out there and so many publications clearly indicating there's enough long-term effect, but I just wanted to show you one fact which was published in Journal of Pediatrics in United States. And I wanted to focus in these squares here. I compared the blood pressures between offspring with non-diabetic mother, about 80 kids, and then offspring diabetic mother, about 100 kids. And the mean age was about very similar. Body BMI was a little bit higher in an offspring. But look at the systolic, diastolic mean arterial pressures in this age group in offsprings. They are significantly higher in an offspring of diabetic mothers on this right side. So we started to find out what is causing this, why there's showing the higher level of blood pressures in offsprings. So we went back. Remember, we draw the amniotic fluid during their pregnancy. We froze those samples. We thought them, started to look at it, see what factors are actually higher, correlated with child blood pressure during their teenager. We found strong relationships. It started showing in the second trimester too, but strong relationships with beta hydroxybutyrate and free fatty acids. What is this? This is ketone body. Clearly indicating mother's diabetes not well controlled, then it is started programming during the fetal development where the hemodynamic controls are occurring. So it is programmed even the second and third trimesters, and during their teenagers, it's already starting showing high blood pressure levels there. What about with the mother, which I have shown you enough the adverse effects in offsprings? Let's look at the mother. This is what we found and published in DRCP. If you follow women who experience gestational diabetes for 3 years, about 40%, about 40% develop diabetes during their postpartum follow-up period. When you break down by A1, A2, B1, this is the Weiss classification, GDM classification during the pregnancy. The observation is different. A1, which is more, the B1 is more severe form. About 50% develop diabetes within 6 months postpartum, and that plateaus. And within 5 years, about 80% develop diabetes. Whereas in A2 and A1 is less severe form. About 30% develop diabetes during the 5 year postpartum. But in A2, again, about 50% develop diabetes and during postpartum period. What if you compare those individuals with a normal pregnancy? The bottom part is the similar age group and showing the prevalence of diabetes. In age 30 to 34 women who did not experience gestational diabetes, their diabetes rate is only 3%. And 35 to 39, about 5%, they're all less than 5%. But if you look at the women who experience gestational diabetes, they are 5 times or even greater than 4 times higher risk for type 2 diabetes. Relative risk, 4 means they are about 400% higher rate. So here's the take-home message for you. Diabetes in pregnancy continues to increase in Asian countries. GDM is associated with adverse maternal and fetal outcomes. At greater risk for diabetes after GDM, but it is preventable. Because of time being, I did not bring a slide, but if you lose about 4 kilograms after the pregnancy, there is a prevention rate of about 250%. That is also published in diabetes journals previously. So if you're interested, just type my name and then you'll find that the publication. So what can we do about these women with experienced gestational diabetes? So let me cover a couple of slides related to the clinical care. Managing GDM is very important. Blood glucose should be monitored up to 4 times during the day, upon awakening for a fasting level, and 1 hour after the first bite of each meal. The fasting glucose level goal is to try to put it in between 70 to 90 milligram per DL, and postprandial goal is ideally 120 milligram per DL, but it is acceptable if you could bring it down their postprandial level to 135 to about 140 milligram per DL. What about diet therapy? Yes, there is a diet therapy, but it is important because they are pregnant. So quality nutrition intake is essential, but caloric allotment is based on the ideal body weight, as you can see on this slide. If your ideal body weight is BMI is 20 to 25, the treatment is about 30 kilocalorie per kilogram body weight. If they are very heavy, obese, then you're down to 12 to 15 kilogram body weight per kilogram body weight. And of course, there's the allocation of the carbohydrate with about 33 to 40%, and fat 35 to about 40%. and protein 20%. This caloric distribution will help about 75 to 80% of GDM become a normal glycemic, simple diet treatment. What about the exercise? Exercise has been shown to improve the glycemic control. The mechanism of this improvement is mostly secondary to increasing tissue insulin sensitivity. It is not clear exactly how much exercise is enough to help control glucose levels, but exercising 3 or more times a week for at least 15 to 30 minutes, simple walking during this type of the recommendation, exercise both prior to the end during pregnancy has a great correlation with protection against developing GDMs. So when you observe the women during the pregnancy, you see the glucose level started going up. Simple treatment of the advising exercise is well enough to reduce their glucose level. What about hypoglycemic agents? In the United States, use of oral hypoglycemic agent is still controversial and not approved by US FDA. US used the glyburide to manage GDM when diet alone was insufficient, although a significant number of these patients go on to require insulin in order to maintain optimal glycemic control. Metformin is considered as a substitute to insulin. There was less severe hypoglycemia in the infant mothers on metformin. Preterm birth weight was more common in the metformin group, but there was no increase in other complications. Women who used the metformin were more likely to say they would use the metformin in a subsequent pregnancy with about 76% than women on insulin because they have to inject. There were more fear related to the injection, so the use of metformin was good enough for women, or they preferred to have a metformin. Among those women on metformin, 46% had to be on supplemental insulin as well. Metformin was a safe option for GDM, and it was more agreeable to the patient. There have not been any trial comparing glyburide and metformin as of today. Of course, there's another therapy, insulin. There's no consensus as to when to initiate insulin therapy, but more conservative guidelines are in place to help minimize macrosomia and its associated risk to the infant. As you could see, there's long-acting and intermediate-acting, and the bottom of the slide shows how you supposed to treat if the patient requires the insulin therapy, and the breakdown of initial dose, the 1 to 2, and then 1 to 1 in PM ratio. Insulin ratio is short-acting to intermediate-acting. Usually about 15% of the pregnancy require insulin therapy, and most of them go in oral agent or the exercise or diet. So postpartum care is also very important. Blood glucose should be monitored the day after delivery to ascertain that the mother is no longer hyperglycemic according to the criteria for non-pregnant individuals. In general, no further insulin is required postpartum for patients with the GDM. Among women with the GDM, 95% will return to a completely normal glucose status postpartum. In the postpartum period, glucose tolerance screening should be performed at 2 to 4 months after delivery, but most at before 6 months, then 3 to 5% of women who remain diabetic and require further treatment. We recommended the 75-gram 2-hour glucose challenge test for the postpartum care. Thank you very much for your attention.
Thank you, Professor Nam-Han Cho, for this interesting presentation. And now we follow by SGLT2 inhibitors' impact on cardiovascular outcomes. Professor Mike.
Thank you, Mr. Chairperson, and Mrs. Chairperson, Lady Chairperson. Ladies and gentlemen, good afternoon. I'm Mick Mwenda. I'm a consultant nephrologist from the UK with very much interest in diabetes. And many thanks to Ines and faculty for inviting me to take part in this wonderful congress. I'm going to talk about this group of oral hypoglycemic agents, which I think are pretty much exciting. Whoa, beg your pardon, I told you it was exciting. And in that, it gives us some more options as to how we treat type 2 diabetes. And also there's some things coming up in terms of how these agents are working to have an impact. They seem to be having an impact on cardiovascular disease. And to do that, for the first time, we're going to kind of look at the kidney as a very friendly organ for the diabetologists. It used to be an enemy because it used to cause end-stage kidney disease and high risk of cardiovascular disease. But I think now we recognize that the kidney is actually a friend of the diabetologist and is now part of the treatment for type 2 diabetes. I'm going to look at some of the renal and cardiovascular outcomes, and then we can also quickly talk about adverse effects. Any pharmacological product, no matter how superior, will have problems. So here are the glucose transporters in the body. There are several different types. I have no intention of going through all of them. They're the glucose transporters, and then there are the sodium glucose co-transporters that are occurring in different tissues. But for the sake of this lecture today, we're going to concentrate on the kidney, particularly the sodium glucose transporter 1 and 2. It's been around, this concept has been around a long time. Fluorescein was isolated in apple tree bark as far back as 1835, and it was recognized later on to be an inhibitor of sodium glucose transporter 1 and 2. The glycosuric effect was demonstrated as far back as 1865, and then the renal actions identified later on in the 1903 in rat models and in humans in 1933. And the famous anti-diabetic effect was discovered in 1987. What they do is already well known to yourselves, but this slide summarizes what they do. They are the intrarenal mechanisms, so they reduce the initial impact on the kidney filtration as the patient becomes diabetic. So you get that hyperfiltration, which if persists can damage the kidneys. And they do so through improving healthy tubuloglomerular feedback, sodium, reducing sodium reabsorption, and then similar kind of impact if you block the effect that you may see with ACE inhibitors and angiotensin II receptor antagonists. They protect proximal tubule glucotoxicity, reduce tubular cell hypertrophy and hyperplasia, and by doing so, they reduce production of or excretion of albumin in the urine, which in itself is renal protective. And then there are also the